Hi, my name is Stefan Helms, and I'm presenting a case about a patient who presented with microscopic hematuria and polyarthritis and was ultimately diagnosed with granulomatosis with polyangiitis. So granulomatosis with polyangiitis, also known as GPA, is a vasculitis that affects small and medium-sized vessels, causing a wide range of symptoms across various organ systems. ENT manifestations occur in GPA patients with an estimated frequency of about 90%. Pulmonary symptoms are also common. Glomerulonephritis is present in 20% of patients on initial presentation, while cutaneous signs are present in approximately half. Neurologic, ophthalmologic, GI, and cardiac manifestations are less common, but they do occur. So for the case, we have a 58-year-old male with a past medical history of type 2 diabetes, hypertension, and 2 years of asymptomatic microscopic hematuria, who presented to the rheumatology clinic at the West Palm Beach VA with several weeks of arthralgias in his shoulders, knees, ankles, and also presenting with morning stiffness. He presented to his primary care physician the week prior with similar symptoms, and the blood work showed ESR of 41, CRP of 10, while the urinalysis showed microscopic hematuria. At that time, the patient was told to take NSAIDs prior to his rheumatology referral, which was placed, which provided significant symptomatic relief at that time. In the rheumatology clinic, his vital signs were within normal limits, and his physical exam revealed only pes planus and crepitus in the right knee. Further lab workup showed a positive C-ANCA of about 3.3 and a positive rheumatoid factor with an otherwise normal rheumatological panel. At that time, he continued using NSAIDs and presented about a week later with a new pruritic rash on both of his lower extremities. He was started on Kenalog 40 mg IM and prednisone 20 mg daily for his polyarthritis and rash, which rapidly improved all of his symptoms. He was referred to dermatology for the rash, and a subsequent skin biopsy of his lower extremity rash revealed granular deposition of C3 in the superficial dermal blood vessels and general findings consistent with small to medium vessel vasculitis. At this time, urology was consulted to investigate the microscopic hematuria, and they performed a cystourethropy, which was negative. Urine cytology was also negative. A right renal core biopsy was performed to rule out GPA, and the results were sent to Brigham Hospital in Boston, which revealed active glomerulonephritis suggestive of GPA. Rituximab was initiated, but the patient had an adverse reaction, so he was ultimately started on Cytoxan 150 mg PO daily, prednisone 20 mg PO daily, and Bactrim 3 times a week for PCP prophylaxis. His symptoms have significantly improved ever since. And in the center of this poster here, you can see some of the lab results that were obtained, and also the report from the renal biopsy at the very bottom. And at the very top, I've included a little diagram that can show the ways in which various organ systems can be involved. So ultimately, this case illustrates the varying and often misleading ways that GPA can present. In this case, despite exhibiting several signs of GPA, this patient did not show the disease's hallmark ENT and respiratory symptoms, and therefore required a kidney biopsy months after first presenting to the clinic for a final diagnosis. It is therefore important to always consider GPA in patients who have microscopic hematuria without an obvious cause, even if ENT and respiratory symptoms are present. Thank you very much.